Dear chairs, dear audience, let me present my 6 months progress in the topic of novel approaches in treating pancreatic ductal adenocarcinoma. My name is Melinda Piri. I'm a clinical oncology resident and a PhD student. In my vision, pancreatic cancer one day could become a curable and if not, at least a chronic disease. And to achieve this, my mission is to find novel treatment options to enhance the survival rates in PDAC patients. We launched 2 projects last autumn. The first one focuses on a special subpopulation of PDAC patients, of the oligometastatic patients, and the second one tries to establish the role and place of targeted therapies in the treatment of advanced PDAC patients. So let's see some numbers why we have a devastating need for new treatment options. Pancreatic cancer is the 3rd leading cause of cancer-related death in the United States, and of all the pancreatic cancer patients, 90% are pancreatic ductal adenocarcinoma. And the incidence of PDAC is rising worldwide. And the most devastating information on this slide is that more than 80% of the PDAC patients present with an advanced stage disease, as it is often remains asymptomatic for a long period of time, and these patients are not eligible for a curative intent treatment. So, my first project, evaluating the efficacy of multimodal treatments in oligometastatic pancreatic ductal adenocarcinoma. Here, we are focusing on the oligometastatic patients, as I already mentioned. Who are they? We are talking about an oligometastatic disease if there is a limited number of metastases present at a limited number of sites. These can occur either synchronously, in the same time with the primary tumor at the diagnosis, or metachronously, after the definitive treatment of the primary tumor. And what are the basics? Why do we think these patients might benefit from a more aggressive approach? The basics rely in the theory of branched evolution of tumors, which states that in a tumor mass, there are distinct subpopulations of tumor cells evolving next to each other. And we know so far that for a quick metastatic propagation, we need a strong clonal driver which can drive this propagation. And if there are distinct subpopulations which evolve parallelly, they have their own clonal drivers, which are either weak or they interfere with each other if they are stronger. Therefore, we have a time period when the whole tumor mass have a reduced metastatic efficiency and capacity. And in this time period, we have a chance to cure these patients. Therefore, we believe that this patient might benefit from a more aggressive approach from metastasis-directed multimodal treatments. However, the guidelines still do not recognize these patients, and the standard of care for them is the same as for the polymetastatic ones, systemic chemotherapy. Therefore, we would like to investigate the impact of these metastasis-directed treatments on the survival of these oligometastatic patients. So the question is, do metastasis-directed multimodal treatments provide a better prognosis compared to the standard of care? We use the PICO framework. Our population is oligometastatic patients who undergo systemic chemotherapy. We have 4 subgroups of intervention, which are the different options for this metastasis-directed therapy. So surgical removal, radiation therapy, interventional radiology, and any kind of combination of these local treatments. A comparator is no additional treatment to chemotherapy, and our primary outcomes are overall survival and progression-free survival. Our hypothesis is that multimodal treatment provides a better overall and progression-free survival compared to the standard of care. And our clinical and research implication is to improve the survival rates. So we use the following search key to conduct our systemic search in 3 databases. The first 2 domains refer to our population, the oligometastatic patients, and the third one refers to the systemic chemotherapy, as everyone has to receive that. During our preliminary searches, we have found previous meta-analysis. However, they only focused on the surgical approach, and we haven't found any Prospero registration yet. So our search key led us to almost 10,000 articles, and after the title and abstract selection and full text selection, we ended up with 36 eligible articles, and with the citation and reference chaser process, we added additional 27 articles to our pool. So the progress of my first project is the following. So we finished the full text selection in January, and we are working on the data extraction now. We are halfway through the data so far. So let's jump to my second project, investigating the effectiveness of targeted therapies in advanced pancreatic ductal adenocarcinoma. So as I already mentioned, advanced PDAC is a major health burden, and so far we only have chemotherapy, basically, which is proven to improve the survival rates, which are still very low. So we also need treatment options in the systemic part. One of these immunotherapy. However, the microenvironment of pancreatic cancer is immunosuppressive by nature, so as a monotherapy they tend to fail. So the other option are targeted therapies, and with the genomics now we know that PDAC has a low mutational burden, and its molecular profile is driven by carrier mutations, which are hardly targetable. On the table you can see the currently available targeted therapies based on the NCCN guidelines, and we have only one very specific mutation we can target. Therefore, the role and benefits of targeted therapies in the overall PDAC population are still not well established. Therefore, we would like to investigate the effectiveness of these therapies. So our clinical question is, do different targeted therapies improve the survival compared to the standard of care in advanced PDAC patients? We use the PICO framework again. Our population are now advanced PDAC patients. The intervention is targeted therapy, and the comparator is no targeted therapy. Our outcomes are the same as before: overall survival and progression-free survival. And we hypothesize that targeted therapies improve the survival in PDAC patients. And the clinical and research implication is the same as before: improve the survival rate. So we have this preliminary search key, which is quite preliminary. We are still working on the conceptualization, because there is a chance we could do a network meta-analysis from this. And as a quick summary, we plan to submit the first project about oligometastatic patients in September this year, and we are very optimistic and plan to submit the second one in December this year. And let me finish my presentation with the words of Werner von Braun, who was a key figure of Apollo project. Research is what I'm doing when I don't know what I'm doing. Thank you for your attention.
Thank you for your presentation. In your first project, based on the full text selection, what was the most frequent combined therapy in the literature?
Most frequent combined therapy?
Yes.
Well, I would say surgery plus radiofrequency ablation of the metastasis plus chemotherapy. That's the most used one, I believe.
Congratulations on your presentation. I would like to ask you, how many of the pancreatic cancer patients are really oligometastatic, and out of these, how many are eligible for local treatment?
Actually, there are quite low numbers in the studies I have read so far. So it's around 10 to 50 patients in every article, and they did their retrospective research in a 10-year time period usually, but at least 5. So there is very few patients so far, but I believe that we do not pay attention for these patients that much that we should, and we treat them as polymetastatic, even though we could treat them more aggressively.
Okay, thank you.